Good evening, everybody. I'm Hannah. Welcome to the fourth edition of Colorectal Cancer Canada's webinar series, Tush Talks, where we discuss a variety of topics pertinent to colorectal cancer patients and their caregivers. We are in conversation with professionals to uncover information that the community needs to know and to raise important questions. So tonight we're very excited to be joined by Dr. Ann Katz. Dr. Ann Katz is the certified sexuality counselor and clinical nurse specialist at CancerCare Manitoba in Winnipeg, Canada. Dr. Katz is the immediate past editor of the Oncology Nursing Forum, the premier research journal of the Oncology Nursing Society. She was inducted into the American Academy of Nursing in 2014, and she's the author of 15 books for healthcare providers and healthcare consumers on the topics of illness and sexuality, as well as cancer survivorship. It's a lot of books. Her book, the second edition of Women, Cancer, Sex, was published in late 2020. And I know that she's working on another one, I believe, yes. Welcome, Ann. I'm not allowed to call you Dr. Katz. So welcome, Ann. It's a pleasure.
Thank you so much. It's really a pleasure to be here. So if you just give me 2 seconds, I am going to share my screen and try not to make a mess of it.
Okay, I should mention actually, so I'm sure whoever's listening does know that we are talking about oncofertility tonight, which in other terms is fertility preservation. This is a topic that is unfortunately not widely discussed. We get a lot of information from patients that this is something that, when they're of childbearing age, that it's not necessarily a topic that comes up with their physicians, with their oncologists, radiologists, and there are some very important things to be aware of in this area. So Anne will enlighten us this evening.
I hope so. So thank you for logging on, for attending. I'm happy to be doing this for Colorectal Cancer Canada, and especially for the young adults or people of childbearing age, and that's a little bit different for men and for women. And I'm going to just walk you through some of the background, including a lot about patient or survivor perspectives. On this, I'm also going to be talking about what's going on in Canada. So, adolescents and young adults are concerned about fertility. It's not all about sex, drugs, and rock and roll. It's also about those really important developmental milestones that particularly young adults have to achieve. And one of them is establishing a family. Of course, it's not something that everybody has to do, but certainly creating family, is something that there's often an expectation, certainly from parents, right, that you're going to give them grandparents. So, you can see here from a fairly recent study, actually 2 studies, that, overwhelmingly 80% of survivors and their parents want biological offspring. And I think that's important. However, a much smaller number, less than 20%, reported that anyone had talked to them about fertility counseling. And as I talk this evening, you're going to see why it's important to have this discussion before treatment starts for the most part. And almost half in one of these studies was concerned about what treatment for cancer generally would have on their fertility or the ability to conceive or carry a child. It's important, I think, to note that there's actually been very little research specifically with people of childbearing age who have been diagnosed and treated for colorectal cancer. Most of the research has been done in breast cancer, in hematologic cancer, so leukemias, lymphomas, cancers that are more common in young adults. Unfortunately, we're now seeing increased rates of colorectal cancer in young adults, which is not something that any of us are happy about, I can assure you. So I'm going to start with men. I don't know why I always start with men. Next time I do this talk, I'm going to flip it around. At any rate, we know that there are certain treatments that are higher risk to fertility than others. And unfortunately, we also know that there are treatments, particularly the newer treatments, that we just don't know what the risk is. I think this will become apparent as time goes by and we use these medications more and more. I have highlighted the treatments that are of particular interest or particular importance to individuals with colorectal cancer. So any of the alkylating agents really have the biggest impact on fertility, as well as pelvic radiation. And certainly radiation for colorectal cancer will often involve the pelvic organs, depending on where the lesion is. And then intermediate risk surgical procedures. But I have to tell you, I see a lot of men who've had an anterior resection for colorectal cancer, and they have enormous problems. They have enormous sexual problems because the surgery is really, really brutal. And, you know, it can interfere with, for example, erections. It can interfere with the prostate. So even though, you know, the surgery doesn't directly target reproductive organs, there's enough damage done because of the brutal surgery. So what we see in men is either reduction in sperm production, which means a low sperm count, or no sperm produced at all. And this is actually fairly easy to test. So, well, it's easy for me to say as a woman. I don't have to sit in the room on the chair and produce a semen sample. But somebody will look, an endocrinologist generally will look at the semen under the microscope and give a report about what the sperm look like, if they are swimming normally or swimming sideways because they didn't ask anyone for directions. That's a joke. Whether they are swimming fast enough. They will also count the number of sperm. So this is a semen analysis that is done quite frequently to see what the situation is, both before and after surgery or any other kind of treatment. So we have, you know, really good evidence that the established fertility methods or fertility preservation methods work really well for men. So essentially, if there are live sperm that look good, that look healthy in the sample that the man produces, those sperm are then sent for cryopreservation or freezing or banking. If there is really reduced sperm or no sperm, they will try their hardest to freeze some, because honestly, it only takes one single sperm to create an embryo, a fetus, a baby. If there is no sperm in the sample, they can actually try and get sperm out of the bladder, because often after surgery, there's what we call retrograde ejaculation. So instead of the semen coming out of the penis, it actually sort of backtracks into the bladder. So they can actually get some from there. Or if that fails, they can actually get sperm out of the testes themselves. And I know that sounds like a whole lot of fun. And if the man is unable to ejaculate for whatever reason, and this can actually be done for pubertal boys, where this is really, you know, embarrassing and really very delicate. When the young man is under anesthetic, they can actually do vibratory stimulation of the prostate and in that way get a semen sample. Of course, the young person is under anesthesia and doesn't know that this is happening. So that spares a whole lot of embarrassment and trauma. I mean, let's face it. And then during cancer treatment, they can shield the testes with these steel plates that are part of the linear accelerator. So shielding the testes is actually quite a normal procedure for anyone of child conceiving age, I guess you would say. There are also a number of experimental techniques, and this is an area where there's a great deal of research going on. So there's testicular sperm extraction, which I talked about, where they get one or more sperm actually from the testes. Then more experimental is testicular tissue cryopreservation, where they take strips of the testicles themselves and freeze those, and then later actually graft that tissue back into the man's body in the hopes, and this is experimental, in the hopes that that tissue will engraft, it'll grow and start to produce sperm again. So I know this sounds a little bit like the Wild West, or sci-fi. I've attended an oncofertility conference in Chicago up until 2020, when the world kind of stops. And it's been really interesting to see how much progress is being made in these experimental treatments. And it's really quite fascinating. So, you know, what's actually happening on the ground in terms of both cryopreservation of semen as well as use of it, I think is important. And this is really new research from 2019, 2020, and 2021. So that's new. So in one study, between 8 to 100% of men undergoing treatment for cancer were offered. Now that's a very broad range. I'd like to see this offered to everybody, for men, no matter what their age, right? Because you could have a 58-year-old man who has a partner of childbearing age, you know, maybe a second or third relationship, or just someone who took a long time to settle down. However, between 3% and 79% actually preserved semen. So there's a big difference there. But, you know, I think, you know, almost 80% actually banked sperm. That's great. I'd really like to see more of that. So here we actually have some data on men with colorectal cancer, just 3.4%. And you can see that almost twice as many men under the age of 35 compared to men between the ages of 36 and 40 banked sperm, low uptake. So only 10% or 11% of men who'd had chemotherapy actually used that cryopreserved sample, and 8% of men who had radiation. This does not mean that those men did not cause a pregnancy. We don't know that, right, from this study, because they may have been fertile, right? It only takes one. And from another study, less than 50% of men who banked sperm actually achieved parenthood. And that does not mean that the techniques, the in vitro fertilization, etc., didn't work. It just means that less than 50% conceived a child. So the situation is a little bit different, well, a lot different for women. So here we see, you know, in many ways, the same, the alkylating chemotherapy, pelvic radiation, as well as abdominal radiation in women pose the biggest risk. So what happens with women is either they have what we call acute ovarian failure. So because of the radiation or particularly chemotherapy, the ovaries just shut down. Chemotherapy, as you know, is aimed at rapidly dividing cells, and the eggs or ova in a woman's ovaries are rapidly dividing by definition. So this is why with, you know, for example, with an alkylating agent, often there is acute ovarian failure. So the woman no longer menstruates, she is not ovulating anymore. We also sometimes see, depending on the chemotherapy agent or perhaps radiation therapy, what is called premature ovarian failure, where there is earlier menopause than the average age of women in that family. The average age of women of menopause, not the average age of women, the average age of menopause in Canadian women is 51.2 years. But, you know, if a woman's mother went through menopause at the age of 46, which happens, she is also more likely to undergo a menopause round about that age. But with premature ovarian failure, we see this probably about 10 years before she would have normally gone through that. So, for example, a woman who would be expected to go through menopause starting at around age 48, her window of opportunity to conceive is much, much smaller, much narrower, because she's probably, because of the treatment, going to go through menopause in her mid-30s. And today many women are just starting to have babies when they're in their mid-30s, out of choice, out of career, out of wanting to travel, a whole bunch of stuff. So this obviously is something that needs to be taken into account. So, we also know that even if a woman does see the return of periods after treatment, or if her hormone levels are normal, that does not mean that her ovaries are fine. You can see here that, more than twice as many women in their 30s are going to go through premature ovarian failure and menopause compared to women under the age of 30. So the older the woman is, the less likely she is going to be able to conceive. So, we see here that for women, age, as I just explained, the dose of chemotherapy, the type of chemotherapy, where she was in her reproductive age, all will impact on her ability to conceive, even though chemotherapy generally for women has a lower or moderate risk. We don't use those alkylating agents all that much anymore. And of course, for women who are going to have pelvic radiation, they're going to do that transposition of the ovaries. Now, this is laparoscopic surgery, right? For men, we just shield their testicles because they're hanging outside their body. For women, they actually have to laparoscopically, so with keyhole surgery, go in and move the ovaries up a little bit and out of the radiation field. So for women, embryo banking is the most established method of preserving fertility. So the woman would get medication that stimulates the ovaries, so she produces a whole whack of eggs. Those eggs are extracted, and then they are mixed with either a partner's semen or with donor semen or donor sperm, and an embryo is created, and the embryo is frozen. Those embryos actually freeze and thaw really nicely, and this really is the most successful method of in vitro fertilization. Oocyte banking or egg banking used to be, and I think even 5 years ago, we used to talk about this as experimental. It is now widely accepted. I'm going to talk about the success of this later, but this is where the woman doesn't have to go through that whole process of mixing her eggs with sperm. The eggs themselves are frozen. Then there's radiation shielding as well as ovarian transposition. So these are the established methods. There are experimental methods as well. The one is they take slices of the ovary, freeze that, and then implant that after treatment is over. This is still regarded as experimental. There have been a couple, not very many, live births from this. And now ovarian suppression, where women are given medication that actually kind of puts their ovaries to sleep and avoids the damage from chemotherapy. This is done a lot. The evidence for it is not that great, but it's done. The medication has side effects, but certainly, the hope is that this is going to protect the ovaries from the insult of chemotherapy. And I'm not going to say that this is standard practice because the medication is really expensive. It's about $1,500 a dose, which lasts for about 3 months. So it's expensive. It is done. And often things are done because it provides healthcare providers with hope. I mean, it provides the patient with hope too, but we like some hope. Of course, there are alternate ways of creating family. You can use donor eggs if the woman's ovaries have shut down with a partner's sperm. You can actually get donor embryos from a couple who has banked a number of embryos, decided of the 5 that they froze, they only want to use 2 and they have 2 live births from that. So then there are 3 embryos left. Some couples are willing to donate those to somebody else, but of course, then that's not biological, if that's really important. Certainly, gestational surrogacy, where either frozen eggs from the woman and with her husband or a donor sperm are created, and somebody else, a surrogate, carries the pregnancy. So for example, this can happen if a woman's had pelvic radiation and her uterus has been damaged and is not going to be able to carry a pregnancy. And then certainly adoption. There is strict legislation in Canada around this. No money can change hands, unlike in the States where you can pay a surrogate to carry a pregnancy for you. In Canada, you can't. You can pay for, for food, for clothing,
For their care.
for vitamins for the surrogate, but you cannot actually pay them cold hard cash. The Assisted Human Reproduction Act of 2004 is actually under revision at the present time. So, things have moved along since 2004. I mean, that's almost 20 years ago. So I look forward to seeing what's going to come from there and how it's going to change. Perhaps more importantly, I'm going to talk a little bit about what it means to people who have been diagnosed and treated for colorectal cancer and cancer in general. So, we know that people who are concerned know that their fertility has been impacted or often distressed by this, which turns into generalized distress and often anxiety and depression. Infertility has a negative impact on quality of life, on the relationship. Couples, individuals need to mourn and grieve this loss of potential. Some couples, it causes friction. There's concern that the unaffected, by unaffected, I mean the partner who doesn't have cancer may leave. However, for some people, it actually, knowing that you are infertile can actually kind of help to accept where you are. Accept what has happened and move on, even though it's sad to lose that potential. Cancer in young adults is known as a biographical disruption. It interrupts the normal developed milestones, creating a family, finding a partner, establishing a long-term relationship, establishing a career, having children. So it disrupts the normal way things are supposed to go. And we see that women will often experience emotional distress and difficulties adjusting to the new situation. For men, it tends to be a little bit more ambiguous. However, study after study has shown that men also have a desire for biological children in many different ways. And certainly, if you have had treatment and you're establishing a new relationship, this really can become a make or break thing, that a prospective partner may really want to have children. And if you are not able to either, cause a pregnancy or to become pregnant, this can be a deal breaker, which, is also emotionally traumatic. So Jane Usher is an Australian researcher who's done a lot of work in this area, and this is a fairly recent study from her where somewhere in the range of I think almost 200 men and over 200 women, I think it was 265 women, answered a survey about fertility. And then a smaller sample, 61 women and I think 17 men, took part in one-on-one interviews, lengthy interviews where they, the researchers could really dig deep into all of this. And they came up with these themes, right? So from what they saw in the survey, in the answers to the surveys, and what came out was that parenthood is an essential part of being an adult. That and I know we talk about adulting now, and adulting can mean getting a job and being responsible, I don't know, getting a labradoodle, but certainly having kids certainly changes your life in a very substantial way. And for many of us it really meant, oh yikes, I really have grown up. infertility can be a threat to gender identity. So, if women feel very, very strongly about the role of having a child in their female identity, being infertile can certainly disrupt that. In vitro fertilization, sort of these new reproductive technologies, take a long time. It can be a multiple year struggle for couples or an individual to conceive, and it's expensive. It's hugely expensive, and there is heartbreak all the way along the path. Every month there is this hope that it took this time, and then it didn't. Certainly lots of loss and grief in this, and not just for the individual or the couple, but also for their parents and their siblings who long to be grandparents and aunts and uncles. Some absence of understanding and support, and this is primarily from healthcare providers who sometimes can be a little bit glib about this. Certainly I've heard from my patients, because I do some fertility preservation counseling here in Winnipeg. I've certainly heard from patients where, an unthinking comment like, well, you can just adopt, is thrown out, and it's extremely hurtful because it's not that easy to adopt. And from the study also, this idea that for some people, parenthood is actually more important than, having a great career, owning a home, having a nice car. I mean, all those kind of material things just don't add up in the same way. However, people are resilient, particularly young people are resilient, and life without children is possible. And, there's a lot of freedom and discretionary income to be had if you don't have children. But obviously, I'm not negating that biological and emotional drive to have offspring, particularly biological offspring. This was another study that looked at people who had not chosen to bank reproductive tissue, so eggs, embryos, or sperm. The reason that was given was that the cancer treatment took priority. For those who chose to bank tissue, there was concern about future fertility and wanting to be a parent, wanting to have a child. So the whole issue of, how does one go about this? I want to stress that this conversation needs to be had at the time of diagnosis, because decisions have to be made about how you proceed. And the timing is more challenging for women than it is for men. So I have not infrequently seen a person, a young man, who is going to undergo surgery, radiation, chemotherapy, and literally they will go from my office to the fertility clinic. Do not pass go, do not collect $200, even though you need to collect $200. You need to collect $350, and they have gone directly to the fertility clinic and provided a semen sample. And I know that that's not necessarily easy. And then preferably 48 hours later, go back and give another sample. For women, it used to be that they would have to wait for a certain point in the woman's menstrual cycle in order to stimulate her ovaries. They don't actually have to wait anymore, so they can actually start immediately. So it involves a whole whack of drugs that very often make women feel absolutely awful and very, very hormonal and bloated and uncomfortable, and involves a whole lot of injections, some of which the woman has to do herself. So there can be a delay in the start of treatment, and sometimes that is not possible. And this is why this conversation should be happening at the time of diagnosis. And there may be some people watching this webinar for whom this did not happen. And I just want to acknowledge that it is okay to be angry. It is okay to be resentful. It is okay to be really, really pissed off. And it's also okay to go to your oncologist if you want to and say, hey, why did you not talk to me about this? Just saying. A lot of the research in this area has actually been done in the United Kingdom. I'm not sure why. I know they have a really, really robust adolescent and young adult program throughout the UK, and I think that has something to do with it. However, at the end of treatment, a lot of people do not know what their fertility status is. I'm going to talk about how you find out about that in a minute. And this poses a little bit of a problem in relation to contraception. So I'm going to talk about that too in a minute. Just sort of further to what I said about healthcare providers not talking about this at an appropriate time, there's a lot of gatekeeping. And research has shown that healthcare providers, so oncology nurses and oncologists, and the responsibility really does lie with the oncologist primarily. And I encourage oncology nurses, when I talk to them about this, to open the discussion. If the oncologist has not talked about it, it is our duty as nurses to talk about this. So, we can see here that more men than women are told about this, in part because there is sort of this understanding, and it's often not accurate or up to date, that, men just have to go off and give a semen sample and they can do that today. But for women, it's going to delay treatment, et cetera, et cetera, et cetera. There's no expectation that medical oncologists or radiation oncologists are experts in fertility preservation, but at the very least, they should be referring the patient to the fertility specialists who need to see patients quickly that day, the next day, certainly before treatment starts, so almost immediately. And I'm not saying that this is not difficult. You hear the words, you have cancer, your life changes, right? Everything is turned upside down. And then to have to start to think about, what does this mean? But we know that people have regret, a lot of regret, if afterwards they find out they were infertile and they were never offered the opportunity to explore this further. So this is what I mean sort of by gatekeeping. So more men are likely to receive this information. Twice as many men from this study, it's a new study, 2021, twice as many men as women received information about fertility preservation. 3 times, more than 3 times, 4 times, almost 5 times as many men preserved tissue because of the ease. And there are also, healthcare providers are not unbiased. We make decisions about people's lives based on very, very superficial things. Oh, the patient's told us that he or she is gay, so there isn't an expectation or a belief that these people will want to have children, which of course is 100% wrong. And also the assumption that if someone has a child or 2 children or 3 children, that they're done childbearing, and that is not true. Some people want to have 5, 6, 7, 8 children. Good luck to you. I've had enough trouble with 2, but we should not be making those kinds of judgments. I mean, that's really what I want to say, and those judgments are made. Here's once again a study from Jane Usher, big study, almost 700 women, 185 men. Interestingly, here more women than men had the conversation with their oncology care provider. About the same a number of women and men or their partner raised the issue. This, once again, is an indictment, right? 100% of healthcare providers or oncology care providers should be starting the conversation. We shouldn't leave it up to the patient or their partner, who frankly are gobsmacked, right? In shock, in trauma with the diagnosis. We know that written information is really important because people hear about 10% of what they are told after they hear the words, you have cancer. So it's useless going blah, 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 blah at the patient and or their partner because they're not retaining a lot. So written information is important to take home and read, as is referral to a fertility specialist. We have to remember that from an oncologist perspective, the priority, right, is to treat the cancer successfully. However, if there is no discussion, there is no choice, and that leads to regret. So For individuals who are in a relationship, the threat of infertility or the process of banking tissue, using the tissue afterwards, is stressful. We know that going through infertility treatments or in vitro fertilization changes, very often changes the couple's dynamic, because sex is not fun, sex is there to conceive. Certainly there is nothing romantic or erotic about in vitro fertilization. You know, they might play music in the room, but that's about it. And really, there can be incredible stresses on the relationship, financial stresses, emotional stresses. Often the couple is really not talking about it. And I think I've got another slide about the communication between partners related to this. And for someone who is not in a relationship, establishing a new relationship, you know, this can be a huge source of stress, because what happens if you meet somebody, right? And you have to have this incredibly uncomfortable conversation often about just having cancer, perhaps having a missing body part, perhaps having an ostomy. And to add to that, you've got to say, you know what, I cannot, you know, I don't produce sperm. I mean, however you want to say it, you know, I can't cause a pregnancy, or I can't become pregnant. And then the person ghosts you. And that then becomes, you know, really foremost in your mind as you think about, you know, trying to have this conversation again and again and again. However, you know, resilience absolutely plays a part here. And couples will grow, and often grow stronger because of this, and accepting the fact that they will be biologically childless. That doesn't mean that they will be childless forever. And for some people, you know, the fact of surviving is more important. And often this is a partner's perspective, right? I want you to be here for as long as possible, not some theoretical child that isn't part of our reality. And certainly, you know, strengthening growth in the relationship, what we call post-traumatic growth, optimism and nurturing within the relationship. So it's, you know, there's a lot that's bad, but there is always the possibility of good and happiness and joy that comes from even the darkest of situations. So here's another fairly recent study. And you can see here that for most of these, and certainly sort of the top 4, the top 4, there really is congruence or between the survivor and the partner. So when asked about how the couple worked together to handle these questions around fertility, there was agreement that they worked well together. There was agreement that communication could be better, but show me one couple who has perfect communication, and I will show you something out of Disney. We all, I think, have some blind spots or some deaf spots when it comes to communicating with our partner. I've been with the same person for 45 years, and I tell you something, we get our wires crossed. Even the issue of buffering, hiding concerns to avoid upsetting the other. I always think that this is actually a good sign of a strong relationship, where you don't want your partner's feelings to be hurt. You don't want your partner to be upset. So there's a whole lot of buffering, right? You suck it up, buttercup, and you don't let your partner know how you were thinking or feeling. It's not particularly constructive, but I think it's natural and normal and a sign of caring and love. The last two, there are some differences here. So here, more survivors thought that their partner didn't understand the issues, their concerns around fertility. Whereas the partner, you know, only 14% of the partners, compared to almost 26% of the survivors, thought that the other person didn't understand their fertility concerns. And this may be because the partner perhaps is just really in a different space. And here you see, interestingly, more partners were afraid that the relationship would break down than the survivors. I think that is a really interesting finding here. And you know, I don't know why, but I think that's certainly something that's worth exploring. So, you know, what do we as oncology care providers think and do? And I'm afraid it's a little bit shameful. So we know that there are standards and guidelines around talking to patients about the potential loss of fertility. And those standards and guidelines are not being met for the most part. So a lot of this is dependent on the knowledge of the oncology care provider. And as I said before, oncology care providers are not supposed to be, are not expected to be experts, but we do actually need to know what damage our treatments can cause. So we need, you know, we need some knowledge, or, you know, at the very least, call a fertility doctor and say, hey, you know, this is what my patient is gonna go through. You know, what do you think? This can be a really uncomfortable conversation for some healthcare providers. And what I find interesting is often among my medical colleagues, they'll tell me that they had the fertility discussion. And when I ask them if they talked about the sexual impact of treatment on the person or the couple, they'll say, well, I talked about fertility, not the same thing, different discussion completely. So the comfort level of the oncology care provider is important. And, you know, sometimes the oncology care provider has children the same age as the patient, right? And that makes it really uncomfortable. Or sometimes, you know, it could be, I once had to have a conversation with a 13-year-old boy. And let me tell you something, I am still ashamed of what I did and didn't do in that interaction, because this was the sweetest young boy. He was very, very pale, and he had two bright red spots on his cheeks, like he'd been hit with a bingo dabber. I was probably blushing as well, even though I rarely blush. And it was an extremely uncomfortable conversation that I had with him, because I had to talk about masturbation with a 13-year-old boy. It was not good. I've never made that mistake again. By that, I mean, I do it better now. Certainly, you know, patient or survivor factors. So education, age, partners, relationship status, financial status. There's a whole bunch of stuff that plays into this. I remember one spring, I talked to a young couple. The young man had lymphoma and he was about to start treatment. And I talked to them about the cost of treatment, which in Canada is not always a comfortable thing to do. We're not used to talking about the costs of treatment. Anyway, I put on my big girl panties and I had the conversation about costs. And this young couple looked at each other, and the young woman said, well, I guess we won't hand out favors at our wedding, because she realized that the money that they would have spent on favors, they were going to now spend on him banking sperm. I was hugely supportive, because I think favors are a waste of money, but that's just my opinion. And certainly, you know, if there is educational material, if there are DVDs, videos, pamphlets, books that we can give to patients, it also is really helpful. It makes our job a little bit easier, and hopefully, you know, we know that the patient will read that. And there's a lot of resources. I'm going to talk about them at the very end. There are challenges here, primarily cost. This is expensive, and it's not just the upfront expense, the after expenses. So when you have banked tissue and you want to create a pregnancy, that's where it really, really costs a lot. Whether the person has a partner or not, particularly for a young woman, because we know that embryo banking is better than egg or oocyte banking. But what do you do if you don't have a partner? You know, you're going to ask your best male friend, or you're going to buy donor sperm, right? And then, of course, the whole timing. So, for example, for somebody who has an acute leukemia, they generally start treatment that day, and there isn't necessarily time to bank sperm, particularly for a woman. For a young man, we can do it. If necessary, he can make a sample like in his hospital bed, and hopefully somebody will then take that over through the fertility clinic because it has to be kept at body temperature. So, whoever that person is would have to put the sample in its little specimen jar in a pocket close to their chest and drive it over. So you can imagine if you get your mother-in-law to do that, it's a little bit odd. So this is the situation in Canada, and not that great. So this is the latest that I took from the Canadian Partnership Against Cancer. Essentially, there is no financial coverage other than in Ontario, where the Ontario government will pay for one cycle. And given what I'm reading in the media right now about Ontario Health, not sure how long that is going to last. In Manitoba, the fertility clinic actually negotiated an agreement with the Manitoba government many years ago that you can get a 40% tax credit for any expenses related to fertility preservation. Often for young people, that 40% tax credit actually doesn't mean a lot at all. And we've had we have an ongoing fight with them to try and change this, but it really suits the fertility clinic, and it certainly suits the Manitoba government. There are limited numbers of clinics where this can happen. So, in British Columbia and Ontario has a lot of clinics, and I certainly would suggest that you go to an academic a university associated clinic, because they tend to be more evidence-based perhaps than a private clinic. So 18 clinics in Ontario. In Manitoba, we have one, with another one in the planning stage. Alberta has 4, British Columbia has 6. Northwest Territories, Nunavut, Yukon, 0. Right? So that adds, a huge amount of significant layers on the ability to do anything. So some will do just banking, so they will freeze reproductive tissues. Others also do in vitro fertilization. So, this can also present some challenges. So the situation in Canada is really not that great. On the other hand, we know in the United States, there are many private clinics who do this, where there are issues with their advertising, their promises, and the reality of what happens. So they may have very nice advertising and tell you, that there's 80% of their patients have a live birth within 1 year of starting, and it's really not accurate. And of course, the issues are going to be different for somebody who's been treated for cancer than for somebody else who has infertility for some other reason, and sometimes the reason is actually unknown. So we know that first of all, uptake of stored tissue, as you saw earlier, is low, particularly for individuals who've had cancer. Here the study showed that there was just one live birth from frozen eggs. I think that is changing. Because the technology and the chemicals and the processes are changing, and this is being done more and more and more, but this still remains a challenge. So here from 497 frozen specimens of tissue, there were 50% resulted in a live birth, and 38% of those were from gestational carriers or surrogates. So, once again, this is layer upon layer upon layer of challenges, which are not insurmountable, but it's not easy. It's not what you see on television, right? And you really have to fight hard to be realistic about this. The whole issue of for a woman finding a partner, buying donor sperm, the issues around donor sperm, whether the donor wants to have something to do with any children born from his sample. You may not want that, or it might be okay, but you've got to think about these issues. Certainly for oocyte freezing, for egg freezing, this isn't an issue. And, I know now that, for example, Apple and Google will pay for their employees to freeze eggs, which is very interesting. I don't know, if they really talk about the success of frozen eggs, but society is changing. So, and the costs of that are not small at all. So I think that is really interesting. So, issues around timing, difficult for boys who are prepubescent, and this is where parents are making a decision, right? Because these are minors. For young adolescents, this whole thing is super embarrassing, as you can imagine. They prefer 3 samples, so that really that's 6 days, because they prefer 48 hours between each sample because there's more sperm produced. So how do you know if you, after treatment, if you are fertile or infertile? For guys, quite simple, a semen analysis. So you go off to the fertility clinic or to a lab, and you produce a sample, and somebody is going to look at that sample. It's important to remember that if you do this soon after treatment has been completed, you may have very few sperm or no sperm. But men produce sperm over the course of their life. They produce an infinite number of sperm under normal circumstances. And some men will see the return of what is called spermatogenesis, the production of sperm. So if your first sample, shows, reduced quality, reduced quantity, or no sperm at all, it's important to go back a couple of months later. Caution around that, right? One sample suggesting that you don't have sperm does not mean that you are infertile. I'm going to talk about that in the next slide. For women, they generally do hormone levels, follicle stimulating hormones, and luteinizing hormone. And also they may do transvaginal ultrasounds just to check to see if the ovaries are waking up and there is follicle development. So the eggs are starting to grow again in the ovaries.
And can I interject for a second? So sorry. Yeah, just wondering, so you're mentioning this time frame of, somebody goes maybe a few weeks post-treatment. Is there like a recommended time frame that people should be doing this type of testing?
I would suggest somewhere in the range of 2 to 3 months.
Okay.
Right.
Okay. For men and women, similar.
No, for men, because of spermatogenesis.
Okay.
For women, really the fertility specialist or the endocrinologist is going to give you good advice around that.
Yeah. Okay.
Right.
Great.
Because the hormone levels for women will suggest sort of if she's now, postmenopausal or sort of perimenopausal. Okay.
I see. Okay. Thanks.
So contraception, please, please, please do not assume that you are infertile. And this applies to men and women. You really, really, really don't want to get someone pregnant, whoop, surprise, or get pregnant, whoop, surprise, because you might still be on some kind of adjuvant treatment, right? Long-term treatment. And generally, we do not like women to get pregnant generally within 2 years of the end of treatment. We really want that break. And nobody wants an unexpected pregnancy. It kind of, throws your plans for a loop. Very importantly, you do not want a sexually transmitted infection. And if you're not using a barrier method for contraception, you are at risk for a whole host: syphilis, gonorrhea, chlamydia. None of them sound great. And now monkeypox, just to make things better. Yeah, I tell you something. It's every week there's yet another surprise.
Every week, yeah. Global pandemic, monkeypox.
And you know what? Yeah. It's all about climate change.
Interesting.
Climate change has allowed for all these weird and wonderful viruses to grow, flourish, and be transmitted. So yeah, no plastic straws, people. Walk, bike, try not to ride cars, etc., etc., etc. Reduce.
That's a good future topic. That's a good future Tush Talk topic. Yeah. All right. Okay.
So remember that women, if you're on an oral contraceptive, on a birth control pill, if you're having a lot of diarrhea, your birth control may not be effective. An intrauterine contraceptive device is a really great long-term contraceptive for women to prevent pregnancy. It does not prevent sexually transmitted infections, but if you've had surgery or radiation, which has impacted on the uterus, it can be really difficult to get that intrauterine device, even though they're really small, into the uterus and to allow it to stay there because they can't come out. Condoms work if they're used consistently, and they need to be used with extra lube, not an oil-based lube. The lubricant that the condom comes with is not sufficient, and the number one reason why condoms break is because of friction. So you got to prevent the friction. And certainly for people who have finished having kids, tubal ligation or a vasectomy is permanent. Don't think that, that it can be changed. I mean, theoretically it can, but it's not always successful. So those are permanent. And once again, those don't protect you against sexually transmitted infections. But please, contraception is important. So there are a number of places where you can get resources. Fertile Future, which is a Canadian organization that actually can provide some funding, a little bit sticky because there's a whole process, so perhaps not that useful for women, but they will often cover the costs of sperm banking for men. It's an application process. If you want information that's geared at non-professionals, My OncoFertility or Save My Fertility has really useful information in a very accessible format. The American Society of Clinical Oncology, ASCO, has guidelines. The last guideline was from 2018. I just reviewed it. It is still applicable. And basically, it tells oncology care providers, you have to talk about this. And the expectation is that oncology care providers practice according to the guidelines. And then Live Strong, I'm sorry, I didn't put this on. So Live Strong, which some of you may remember, was associated with Lance Armstrong, naughty, naughty Lance Armstrong. They have disassociated themselves, but they have a calculator that anybody can use as long as you know what treatment you've had. So you need to know the chemo agents, the dosage that you had, the radiation, the dose of gray, which is the measure of the radiation, and you plug this all into the program, and it can actually tell you what your risk of infertility is. I think that's all I have to say.
That was a lot. Incredibly, right? It was a lot, and it was incredibly informative because, having been an early age onset colorectal cancer patient myself, I could tell you that conversation was not had. I just put the Live Strong information in the chat. Having spoken to many others in my role as patient support specialist, I can tell you that this conversation more often than not is not had or not had to the full extent. So yeah, I mean, most importantly, it's conversations like we're having now, and that really provide the the incentive for patients to go and to ask questions, to know who to go to ask the questions. But also, we're really hoping that healthcare providers sort of wake up to the fact, and maybe part of it is, like you said, they're there to fight the cancer, and maybe they don't have the answers. But if they don't have the answers, then they need to be equipped with resources to provide the patients with.
The other thing, Hannah, also is that with testicular cancer, because it's a reproductive organ, with gynecological cancer, so cervical cancer,
It's obvious.
breast
Yeah.
cancer, sort of the obvious ones.
Yeah.
Maybe it's happening more frequently there. But, if you just think about it and you sort of, you follow the dots, colorectal cancer is up there.
Of course, it's within
in
that
the
pelvic
vicinity.
area, right?
Yeah.
Exactly.
Yeah.
And as you said, really important to highlight this is the difference between the conversation about sexual dysfunction, post-treatment, post-cancer, and the fertility aspect. These are not one and the same. So just in that same vein, and like, are these, so it's separate support and separate information, that people, from different individuals, that people get this information. So if you go to a fertility clinic, for example, are you getting the sexual dysfunction counseling, or is it really no? Right? So where do people go for this?
Yeah. So, I have certain expectations of my oncology provider colleagues that at a minimum, they should be raising the topic. And if they don't know the answer, they can say, if it's a fertility related issue, I'm going to refer you to the fertility clinic, and have that association with the fertility clinic that they will see people with cancer within 48 hours, not in 3 months' time, right? And they're a business, so this should not be an issue, right? They're a business, it's for profit. And for the piece, and we've talked about this before, not every cancer center, not every cancer practice has somebody like me who this is what I do. But there may be a social worker, there may be a psychologist who either in the institution, or who patients can be referred to. And I think that every oncology care provider needs to know where they can refer patients, because we don't expect them to know everything about everything. None of us can do that.
Of course. But I think, unfortunately, when we talk cancer, we talk oncology, everyone wants, the oncologist is sort of like the all-knowing, but there are other aspects, there are other team members that can take that on. And it's really just about sort of sharing the responsibility and sharing, resources, but it's also informing these professionals of those resources. That not every center is like CancerCare Manitoba that has this in place.
Yeah, but I also think that it bothers me, on the one hand, that patients have to work so hard to get the information that they need. But on the other hand, I also always encourage patients to be their own advocate, because that is the only way that they're going to get the information that they need, right? And that's a heavy burden to place on someone who has a lot of stuff to think about.
Is worried about survival, not necessarily, right? Like, that's sort of, how could you be thinking about this when you're about to be, to fight the big fight, right? Like, how could you be thinking of what's going to be, and even patients who are diagnosed, with a metastatic cancer, and talking about sort of end of life issues, and, is this something, this must come up. Is this something that patients who maybe are going through just treatments that have no end, does it come up maybe that, okay, we take a break, we try, is that something that ever gets really discussed, or that's just not?
I think controversial. that palliative specialists, and I'm very sensitive to the use of the word palliative, because often it's sort of seen as end of life, blah, blah, blah. Really, palliative care specialists are pain and symptom management specialists, right? And they have these extremely challenging and sensitive conversations and discussions with patients. And, I've certainly done some education in that community around, people are sexual beings till the end of life. And we don't make it easy for people, in hospital, even in hospice, to be alone with their loving partner, and to have the expectation isn't that people are having rip-roaring swing from the chandelier sex, right? But having touch, right?
Intimacy, absolutely. And that comes in many
and the
forms.
intimacy means emotional connection. But that touch, right?
Mhm.
I will never forget a colleague of mine. Her husband was in the palliative care ward, and lying in a hospital bed, and a wonderful nurse came and said to her, "Would you like to lie with your husband?" And as a nurse, she was shocked. And she's well, like, "What do you mean?" And the nurse says, "Come, and put the pillows in between the mattress and the railing, right? Scooched him over a little bit. And my friend said to me that this was the most helpful, the most supportive, the kindest care that they received while he was in hospital. And it frustrates me when particularly nurses, and I take full responsibility for blaming and shaming here, are so task oriented that they don't think about quality of life. They don't think about these things that are important to all of us.
Yeah. And as a continuation of that, I mean, as patients or as caregivers, then they don't think, because everybody looks to the doctors, to the nurses, to the professionals, to their lead, and if this isn't even coming up, then who are we to bring this up? This obviously isn't something we talk about. So I think it does start.
It's not important.
It's not important. Yeah. So even if it's something inside of you that you're feeling the yearning for, you're thinking, how could I possibly be thinking this if this isn't on the table? It's trivial, but in fact, I mean, it's like you said, it's quality of life, and it's an important part of that process. Something to just sort of shift gears. So something, are there clinical trials, like you talk about these experimental type of preservation methods? Are there clinical trials that go on? And if these are sort of if these are procedures that aren't yet tested, I mean, how do people go about discussing preservation methods during those experimental treatments or those clinical trials?
I think that's a great question. So a clinical trial, kind of by definition, is a trial of a medication or a device.
Right.
And generally, what we look for is a placebo-controlled trial, which is randomized, right? So that can't happen here, because you can't say, Hannah, we're going to do XXX, and Iris, we're not, right? No one's going to go for this, right? So really what these studies tend to be, and they are happening, tons of stuff happening in Israel, tons of stuff happening in Japan. Very interesting. And Germany and Switzerland. I mean, I think it's in Switzerland where they did a uterine transplant. Oh. Go figure. Yeah. Like, I'm telling you, wild. I mean, I sat at this conference where they were talking about these things. My jaw was hanging open, right? And they had like pictures. Wow. But so they presented the case of one woman who had a uterus implanted, and I think she had a pregnancy. Huge, not common. Okay. So these studies tend to be what we would call observational, right? Somebody agrees, they try this new technique, and then they see what happens over time. And generally these, these techniques are shared at these kinds of conferences. So it may be, for example, at Mount Sinai in Toronto, that at their fertility clinic, they're trying something new. So once again, I think this is why it's important to go to an academic fertility clinic, because you're going to get, people who are associated with the university, best practice, etc., interested in research.
Okay, and research-based, as you said.
Yeah. So, certainly, listen, this is an issue that is huge in the Western world, where women are, and I'm talking outside of cancer, right? Where women are delaying childbearing for years and years and years. And, this is why you hear about the 63-year-old grandmother that bore her daughter or daughter-in-law's baby. I mean, it's wild, right? I mean, I can't,
Wow.
I'm in that age group. I can't imagine being pregnant.
Yeah.
um, never mind raising a kid. I mean, that's not it. I mean, can you bet? Oh my gosh. But, so there's money. It's big money. And there's obviously a desire to help couples who
Yeah.
are struggling with
Yeah.
fertility issues or struggling with infertility. So,
Okay.
certainly, the whole issue of egg freezing, one of the problems with egg freezing in the beginning, it wasn't the freezing that was the problem, it was the thawing that was the problem. That when
Okay.
they thawed the eggs, they burst, right? I mean,
Oh,
right, what happens to protein in your freezer if it's hanging out there too long?
freezer
Not,
burn? I mean,
not so good. Yeah.
yeah.
Right.
For lack of a
So
better, yeah.
yeah. So now they have better chemicals and processes that
I
the
see.
thawing is more successful.
Okay. And so
Right.
it's more viable in the end,
Correct.
okay.
Correct.
Okay.
And now what fertility clinics are is they're not, traditionally what they would do is that they would take the frozen sperm and place it inside the uterus of a woman who was ovulating, and cross your fingers, hope the two of them get together and something happens. Now
Okay.
what they routinely do is something called intracytoplasmic sperm injection, ICSI, ICSI, where they, under the microscope, take one sperm that looks good, right? Tail, da 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 da, and they actually inject it into one egg.
Oh, wow.
So they do they
do the joining.
the hookup, right?
Wow. The
Is
shutter.
done
Yeah.
under the microscope. Yeah.
Okay. Wow.
And it's hugely expensive.
Okay.
With all the
does
drugs and everything else, it's like
yeah.
$30,000 a pop.
Wow. But that tends to yield more success than the other, I would assume.
Correct.
Yeah.
Because it's
Okay.
leaving less to chance.
Right. So, I mean, you may get lucky on the first cycle, on the first try, as opposed to
Correct.
doing several, and spending the money over several
Right.
cycles. Okay.
Right. But, there are also some concerns that process takes away sort of natural selection, right? Because under normal circumstances, it's the healthiest sperm that's going to be able to do it, right? Because there's competition from the sperm and the egg. And so generally those people will then undergo genetic testing, like very soon after the embryo is created, they take a cell and they do testing to try and rule out any kind of genetic malform, things that go wrong. So it's very, very complicated. And when you think about it, I mean, I think about it from the person's perspective, those hopes, right?
Yeah. Yeah, the hope and, sort of just the stress of knowing what's on the line, the disappointment, but also the financial, as you said, the financial impact on a family is, and especially younger couples. I mean, this is incredibly profound. So on that note about, you gave us that great chart. I didn't see Quebec on there, by the way. And I know, a few years ago, we did have, subsidization for, I think it was the first cycle, possibly second cycle of it. There is no longer here in Quebec. I know that. But just in that, you're talking about money that exists in, fertility treatments and all that. So it seems like a lot of money is going into research, and that's wonderful. But I'm also wondering, are we trending towards more subsidies, more government subsidies? Is this something? No, and there's not a ton of lobbying for this at this point, I guess.
No, and I mean, the other problem in Canada is that we have a number of provincial conservative governments who,
okay,
are fully supportive of for-profit healthcare.
Understood.
It's a problem.
Okay. Yeah, it's a problem. Okay. Because as you said, this is a huge financial undertaking.
But I think it also becomes, it's also, if you do have a pot of money, how do you disperse that? And do you have an infinite pot of money? And are people going to make decisions based on what criteria? Do people with cancer have higher priority than someone who doesn't? But then, people will say, well, you've had cancer. what is your longevity? I mean, it's
Yeah,
awful.
it's Pandora's box here,
Totally. Yeah.
Yeah, okay, that's a really good point as well. So another question would be, these treatments, like, does that then impact? I mean, even if you wait the 2 years or whatever, we know that some of these treatments, the chemotherapy or whatever, it's toxicity in the body. I mean, does this contribute to, fetal, fetal damage and things like this?
Yeah, that's a really good question. And this is one of the reasons why we tell people to wait 2 years.
Okay.
Right. So there is some, for example, there has been some evidence of genetic DNA damage, for example, in sperm.
Okay.
Right. Now, would those cause a pregnancy because they're damaged? I mean, nature is amazing, right?
Yeah.
So, this is why there's generally the risk of a cancer recurring is highest in the first 2 years after treatment. So that is certainly also, I think perhaps an unspoken consideration that people will make. And it takes time to recover. Certainly pregnancy is stressful. That embryo, that fetus is kind of a parasite, right?
Yeah.
On a woman's body. So we want it
in the best condition.
But we also know that people, that women for example, after breast cancer, go on to have healthy pregnancies and healthy babies. And the same for men. But it takes time. It'll often take money. And it takes a lot of patience and a lot of hope.
You're talking about, the fetus being a parasite, or, obviously feeding off of the mother. So question I would have is there any evidence that getting pregnant even 2-3 years after cancer treatments would somehow put you at a higher risk for recurrence of a cancer?
Generally not.
Okay.
Generally not. I mean, I think it might be perhaps a little bit different for someone who has a hormone dependent cancer, but really, that tends to be breast cancer, for example. Some gynecologic cancers have maybe hormonal. Colorectal cancer, isn't as far as I know. And we know that. I mean, people do go on to have children. So, and it doesn't. And there's something called, it's actually from the breast cancer population. There's something called the healthy woman syndrome. That it's that women who go on to have babies tend to be healthier, right? In general, that women who are not healthy are not able to get pregnant, right?
Okay, interesting.
And by healthy, I don't mean like they exercise and eat well, right? That they're recovered and things are working and they're doing well.
Right. Because if the body needs to be in a certain state to get pregnant in the first place. Okay, that's an interesting way of looking at it. I don't want to take too much more of your time, but I did want to ask you a question about, is it important about genetic testing? And so is it important for genetic testing to be done before fertility preservation? I mean, and is this something, in fact, that is being done? Genetic counseling, genetic testing?
Yeah, it all depends on, it depends on a whole lot of things, but certainly women, I think over the age of something in the 30s, will often have genetic testing for Down syndrome. Right. They can look at, it's called nuchal thickening. So they can look at a certain age, they can look at the fetus to see sort of behind the head, to sort of hear where the head meets the neck. That's not super accurate, whereas blood tests, are certainly, for example, There is a risk in Jewish couples of a disease called Tay-Sachs, which is horrible. And that can be done genetically, genetic testing for that. So it all depends, but certainly, obstetricians know these kinds of things. Certainly also, for example, for somebody who has Lynch syndrome, right, which is associated with colorectal cancer, right, it may be warranted there. But, but generally, there's certainly BRCA1 and 2, which has an inherited risk. And we're learning more and more and more about this all the time. So, I think it is not unreasonable to talk, if somebody wants to get pregnant, to talk to their obstetrician, who may refer them, who should refer them, if they have all these questions, to a genetic counselor to see if these tests are warranted.
Okay.
And they cost money.
And yeah, exactly. Doesn't everything, right?
Yeah.
So my last question would be, sort of more of what can we put in our toolbox here? Because that's, really what we're always looking for is, practical, what can patients take away and bring to their team. What are some of the questions, if you don't mind reviewing some of the questions? Maybe one example would be, should I delay treatment? Should I delay my treatment in lieu of this preservation? What are some other really sort of important questions that patients should approach their team with about fertility preservation?
Right. What are the risks to fertility from the treatments that you are recommending for me?
Okay.
Right. What can be done about this? So if the risk is moderate or high, right, I would like to see, I need a referral. I would like a referral to a fertility specialist.
Okay.
Right.
Okay.
I think those are two really good questions to start with, and then let the fertility specialist advise and guide, because they know. And if they don't know something, they will call the oncologist and say, hey, right, what is the risk from this treatment?
Okay. Actually, I said that was my last question, but I'm now coming back to something you were talking about during your presentation. We've had a bunch of patients who've had the ovarian transposition. I mean, is this a reversible thing? I mean, do they then go and sort of redescend the
No, I mean, because the ovaries will function just fine.
Okay.
Right. It's just sort of naturally it's hard for me to kind of switch around, but naturally the ovaries are at the end of the uterine tubes, what we used to call fallopian tubes, but now we try not to call things after dead white men. And
I didn't even know that. Okay.
Yeah. Oh, there's
Dr. Fallopian. Okay.
Yeah, I had just had an interesting discussion with some doctor on Twitter about all the things that we name after people, and it's so stupid.
All the streets in Montreal. Yeah.
Yeah, right. And all your body parts are named after some like dead person, and it's never a woman. So the ovaries will still work. They're just out of the field. So the ovary is released, and then the end of the uterine tube is kind of like this, right? And it sucks it in. Yeah.
Okay. So there's really, it doesn't put you sort of at a decreased risk to get pregnant because of the location. Okay. Right. But still, as you mentioned, it's still, even though it's laparoscopic, it's an invasive procedure. And it's something that, I guess really gives you the best chance to preserve your fertility.
It's part of it, right? Yeah. It's part of it. The problem there is you're moving the ovaries out of the radiation field, but the uterus is probably still in the radiation field, right? And so what radiation can do to the uterus is that it damages the uterus, which will not be able to expand. Right.
Oh, wow.
Big, right? When you're pregnant. So that can be problematic.
Okay, so I wonder how many patients are actually informed about that aspect of things, So on one hand, we're moving, the ovaries, but the other part, the uterus that we really need to maintain the pregnancy could be, at
Could be at
risk.
risk. But then, on the other hand, if the ovaries are okay, right, you could still produce eggs and then extract those eggs and use a gestational carrier or surrogate. Yeah, it's complicated, man.
Yeah,
It
it's really
really is.
complicated. And I
Mhm.
wonder how many doctors are really checking the say the quality, but sort of like, what the uterus kind of like looks like and acts like
Yeah, fertility
following.
specialists will do that.
They do. Okay.
Correct.
Okay.
Yeah, they will do
Following
that.
radiation treatments.
Yeah. But once again,
Okay.
following radiation when the woman wants to carry a pregnancy. So that
Okay.
becomes part of the fertility assessment.
Okay. So the take home really is get a referral for a good fertility specialist. That's probably where you're going to get the best answers.
Right. And even if the answers aren't what you want to hear,
Yeah.
at least you know.
At least Yeah.
Right.
And you're not,
because because knowledge allows you to process, hopefully to accept, and then not experience regret, perhaps that intensely, that badly. You can still have regret, right? But it's not a shock. It's not a surprise. You have preparation.
And you also then can be met with other options, right? Then you can move to a discussion about other things. But really, a hard topic to discuss. There's a lot of sensitivity that has to be used in broaching this topic. As you said, oncologists, nurses, the team is very bogged down with saving lives, so
yeah, I would hesitate to say bogged down. This is the priority. This is the focus.
It should be, right? It should be, but what they may say is, we're trying to save your life and not the life of a potential, of what may or may not be. But a young person who's diagnosed with a cancer, the hopes and the dreams of having a family, can be shattered as a result. So incredibly important work that you do, Anne, educating patients and caregivers and professionals. I mean, most importantly, educating professionals. I know you work so hard to do that on your team and just across, internationally. And just please keep doing this and please keep raising awareness. Please keep coming to talk to us. We always enjoy it tremendously. We will, anybody who's listening to the webinar and has some questions that maybe we didn't, aspects of oncofertility that we didn't touch upon tonight, although and did an incredible job at going from A to Z. Please don't hesitate. Support at colorectalcancercanada.com. And we can, if you want to send in some questions, we'd be happy to forward them and is offered to answer questions that come her way. So support at colorectalcancercanada.com. You can send it there. And thank you so much for tuning in to our 4th edition of Tush Talks. And Anne, always such a pleasure. Thank you.
My pleasure. Lovely to
we'll
see
talk
your face.
soon. Lovely to see yours as well. You too. Okay.
Bye.
Bye.